So, welcome everyone on episode 8 of Mind and Body Wellness Health Talks. And I'm Dr. Kaur from Pengam Health Center. We have got Dr. Inder Singh today. He's a consultant geriatrician and he is also a national clinical lead for Falls. He's a lovely gentleman, hardworking, and it's he's my husband as well. Yeah. He works in Estradmanek Hospital, and I have to appreciate that the way he works. I'm not even closer to that. I'm very grateful that he has given his time for our health and well-being talks. Thank you, Dr. Singh. It's over to you. You're covering osteoporosis today. We are looking forward.
Yes. No, thank you. Thank you for having me. And can you hear me well?
Yes.
Yes.
Great.
Yeah.
So I never actually spoken to anybody in the community, but I do speak to a lot of professional people. So I can see there are about 8 participants, and then including myself. So I think what we need to do here is today to make it quite easy, light, so that we can understand what we are talking today. So, but if you think it's too medicalized, because that's what I do every day, I'm happy to step back and just take some routine questions. And just to get the scene or set the scene, there is that how many of you actually respected your bones before seeing the title for this talk? Whenever you seen this, have you ever thought of your bones?
I've thought about it going through the menopause because our bones thin when we go through the menopause, we're told, but I don't actually know what to do about it.
Excellent. That's a good start for me that you thought of that at the time. And then what happened after that? You stopped thinking about it, or?
I'm just not sure what to do. I drink dairy milk and try to get calcium, but that's about it, really.
That's a really good start. You're doing the right things. You're not buying calcium tablets over the counter. Well done.
No.
Well done. First pass. You got five stars from me. Anybody else who have thought of bones or respected their bones or thought of doing something different?
Exercise?
Resistance,
Exercise. Why do we do exercise for the bones?
Resistant bands.
Excellent. Well done. So
Yeah.
that means you're putting some weight on your bones. Great. That's a good start. Anything else?
Well, I tend to read up.
No problem.
And so I like to keep my knowledge about things up to date. And so I try and do exercises and things like that.
Excellent. That's really good. That's really good. What else you think we need to do to respect our bones? Think.
Eat healthy.
Eat healthy. Excellent. So eat healthy. It should have a good protein diet and a very balanced diet. And that's really good. So you got a lot of points which you already know. So it look like you don't need me much. So what else which is bad for the bones?
Falling.
Sorry?
Falling
is bad because, okay, we'll talk about falls in a minute because falling leads to an injury. So it's not something which is easy to manage, because sometimes, let's say you're nicely dressed and you're wearing a heels and it's very winter and very slippery outside and you're still okay, but somebody push you. That's not your fault. Isn't it? That's not your fault. Falling is not. It's challenging, not bad. It's challenging because we can't manage the risk factors. Somebody is very dark outside and it's not your fault with your vision. It's dark. What you do with that? So the challenges are different. So anything else which is actually bad for the bones?
Sitting down all day.
I think you hear about things like anti-nutrients, and you hear about things like sweeteners and alcohol and things like that. And they take away they take away goodness in your body, and they're
Yes.
bound to do damage.
Absolutely
Ah.
correct. So that is bad for bones, the alcohol, smoking. Excellent. What else is good for bones?
Tummy
Which we
bugger
don't get in
you.
Wales much so. Is there anything which is good for bones but we don't get in Wales?
Sun.
Oh, sun. Vitamin D.
Sunlight. So, so please go for what it is. Perfect. Now, let me bring a little steer to this discussion, but you all have got a really good knowledge of the bones, and it actually helped me a lot. So I don't use this Zoom a lot, but I'm just trying to share. Can I share my screen? It says host has disabled.
Sugar.
No,
My screen.
I'll make you a host and then you can share your screen. Yeah, just
Thank you.
one.
And I must thank my wife actually to bring me here as well. So I had to escape, else I won't get dinner in the house.
Just a minute. So,
Anyhow, whilst my lovely wife is doing that, I can just talk through this. But it's very much different because she actually make all the food, which is all very healthy nutrients, and do tell me
yeah.
not to drink alcohol as well. So which I do drink sometimes.
So I made you host now. You're
Okay.
host. Yeah.
So let me share. So what I'm supposed to do, just pick up something and can you see
Yeah.
my screen now?
Yes, thank you.
Excellent. Well, that's
Yeah.
a really good start. You can see my screen, and by all means, I can send these slides. You can see as many times as you want to see. So there is only a declaration here that I've been paid by the different pharmaceutical companies to do some conference and talking. But that's my declaration. But I don't have any conflict of interest, and I'm just sharing my views. That's Wales. Now, people sometimes, when they see this slide, they get very worried that the older people are growing. So, and they're growing after the age of 50, which is all orange color things. And you can see that the topmost bar is 90-year plus. They've grown by 18% as compared to previous 10 years. So overall, if you look at the population of above 65 has grown by nearly 18% in Wales. Now, there are a couple of things which you need to see from this graph is should we congratulate ourselves, the healthcare system, the social care system we have, that it actually allowed people to grow so well. So this is in one way to be described as healthy and successful aging, which only happen when we treat the stroke and our diabetes and our heart conditions, all this really well. And but at the same time, there is a lot of things done in a primary care, which is giving a healthy lifestyle advice that not to smoke, go for your smear test, go for your breast examination, do this, do that. That all leads to the successful aging. So it's a lot of health and social care work in partnership to do that. But we should congratulate ourselves on this, if I'm honest. But at the same time, there is a lot of worries as well that there is a decrease in the younger population. So, who will look after the older people or people who are growing older? So, when we look at this graphs in 2031, you will also see 100 plus there as well. And that's coming our way. So, we have no escape. So, what we need to do is respect the growing population who is aging successfully, but try to see there is diversity being added now. Where is a diversity with a younger population? Now you had another population group which is older and is growing at a faster pace. So we have to change the way we work in our health so that we can meet the needs for those individuals. But that's what the reality is. It's a very stereotypical part which comes from the government. I'm sure everybody has seen this. That's not right. So now you see, in one respect, we are growing nicely, healthy, successfully, but the government is putting a very much stereotypical type of things. Elderly people crossing the road with a stooped posture and holding each other's hand, but also had a stick. So that's where the risk of falls and stooped posture, everything has been mentioned. But but that's something is stereotypical. So we as humans, we have grown up with the stereotypical attitudes towards older person or anybody who's older than us. So my own children treat me older, but I might treat somebody older than me as older. So it's very relative, but that's the human nature. So whilst we read these two facts, we can't do anything different. What we could see is a spot here. Now that's the story of an individual who comes to us and come with a chest pain or a chest infection, and we treat infection, but we don't see this pink cast. So we don't ask the question, why pink cast? Oh, because I had a fracture. Why you had a fracture? Because I had fallen. But why you have fallen? Oh, because it was a very slippery floor and somebody pushed it. But why the floor was slippery? We need to answer all those questions. But still somebody's forgetting that why a young 67-year-old, or you can make it 87 if you want, they break a bone. So it's just because they had underlying hidden condition, which is known as osteoporosis. Now, this is the time where we need to separate these two things. Until they break the bone, imagine GP or a primary care is doing the health promotion, making your bones stronger. And exactly what we started this discussion, why to respect bones, what is good for bones, what is bad for bones. But once it has fractured, it comes a secondary prevention, because now you are diagnosed with osteoporosis. Until you have broken a bone or you had a scan, you're not even aware that you had osteoporosis. Now, osteoporosis is not same as osteoarthritis. These are the two completely opposite condition, in fact. So osteoporosis is a very thin, brittle bones which can easily break and with very little trauma or energy. But they can also break somebody if give a tight hug to you. So that's how osteoporosis is. So by all means, stop me and ask me any question on anything which is not clear. The question for the health and social care is, why do we need to treat osteoporosis and why do we have to treat right now? An answer to that is, we have to prevent the another fracture, because next fracture is on its way. And if you see this x-ray, you will see somebody had a metal bone, but then they had a second fracture. And this is very expensive for the health and social care to manage. We are talking of approximately £25,000 for 1 year to manage one hip fracture. That's very expensive. So, and by having two hip fractures, you can actually appoint a band 7 nurse in that much money for a year. So now you see why it is important for us. But still, everybody's on this picture. But I am behind the life-changing event. That individual, that person in the community who had a fracture, their life is changed. Their dependency has increased. They won't be able to do things what they were doing. So I often give my own example that if I had my wrist fracture, I won't be able to tie my own turban. But that has a huge impact on me. It might change my life. I might not even leave the room because I may not perceive myself same person. But nobody's measuring or asking that particular person who had a fracture how it affected you. What is your psychological impact of that? What is the psychological impact on your carers who might be living far away from you? They are living with that extra stress, extra carer burden, or guilt that they cannot provide the care to their loved one what they need to deserve. So it changed the whole life of not only one individual, but several individuals. So, but what happens is this important part of life, that this is that particular individual who had no medical problems, not even hypertension or a blood pressure, not even diabetes, and not even arthritis. You might be thinking this is rare, but this is very common. A lot of people have not even on a single medication. But when they start having fracture one after the second and a third and a fourth and a fifth, it add or accumulate that burden of fractures. So the fracture of the wrist, then a backbone, and multiple fracture of the backbone, and most people will see, oh, it's just a back pain, and I have stooped posture. It's normal. And you've seen that lovely picture of two older people crossing the road with a stooped posture. That stooped posture is because of multiple fractures, actually. And these are preventable fractures if we know them. And hence we can prevent a hip fracture to some extent. But we have to be picking up these and identifying this. Now, the bones are living. There are multiple hormones mentioned, and when you mentioned about the osteoporosis, that's so correct. But the bones are living. Now, if you look at this pink thing in this, that means that the bone was broken a little bit, a microfracture had happened after exercise or thing, but it get repaired and it gets stronger. It's a good, healthy bone after that. But these bones are living throughout our life, pre-conception and at the last day of life. They're doing this. So bones are formed, but we forget about them. The only time when we tell children, when they're in school, in toddler group, go out, play in the sun, and go around and jump. You will grow taller, you'll grow stronger. But once they reach the puberty, we just stop doing it, and we don't do much for the bones for rest of lives, if I'm honest. But this is what is very important when we talk about the why to respect our bones is the bones are giving us this tall status. And are you still with me? I believe. Are you still listening?
Yeah.
Okay. So the bones make you stand tall, make you feel confident, make you do, reach things and feel in a way that yes, you are important. It matters. But when you're a stood posture, you look very low, depressed. But it protects you a lot of organs. It store your calcium, other minerals, help you move, and give you all that defense mechanism and hemoglobin, what we are leading. That's all produced in a bone marrow. But still, that attention is not there. Now, I'm going to change a little bit of a discussion on this. Now, I'm sure everybody had heard of diabetes.
Yeah.
Yes.
Everybody talk about diabetes a lot. And diabetes can happen at any stage of their life. Now, you don't have to cram these figures, which I'm going to share, but the prevalence, meaning the total number of individuals who are living with diabetes in the UK is 4.4 million, right? But can you guess the number of people living with osteoporosis is, as we speak today, is 3.8 millions.
Oh,
But still, osteoporosis doesn't get that attention.
no.
And in spite of the fact osteoporosis is a condition which affect the growing population, older people more as compared to younger population. And it's more debilitating. It gets you more dependent on others. It takes you more fears in your mind. Oh my God, if I fall, I'll break a bone. True, true. But it gives you fear. And as a result of fear, you don't leave the house, you don't walk, you don't move. And hence your muscles break down. You get very deconditioned. You lost your confidence. So that's how much bad it is, and nobody talks about that. So so in 2013 in the UK, I do put a lot of pictures because pictures are nice to talk about sometime. And every 2 minutes somebody's breaking a bone above the age of 50, and this is UK. And as we speak today, every minute somebody's breaking a bone, every minute. And this is 3.5 million in 2020. Now it is 3.8 million. The prevalence is growing. So that means something is not right, if I'm honest. That from the health and a social care point of view, something needs to be done differently. And we are very lucky in Wales that the government has taken this very seriously. And we had a huge support from the Welsh government to promote bone health, to raise osteoporosis awareness, and that's why actually one reason I never said no to my wife, but I do say not of no to her. But on this part, I said no. I think you're right. We need to do something. And but that individual who had fracture, half of them cannot walk without using a stick or a Zimmer frame or some sort of aids. And the risk of dying at 1 year is 20%. 1 in 5 will die if they had a hip fracture. That's serious. And 15% could not live independently in their homes. They require a care home. And we don't have many. That's why it's very expensive. But simple spine fracture, 2 and 3 will have that back pain. And that's a chronic back pain. Meaning back pain is there most time of the days of the year. But still, it is associated with high risk of dying. And you do go to GP a lot because you're looking for help, whether you cannot manage anything or you have pain or you cannot do things which you used to do, but you're seeking help, or sometimes you're depressed as a result of that. But the hidden cause is pain, or you're feeling very lonely, and or you have those fears, but you still go to your GP because that's your access. But our primary care is under stress and burden because you don't need to go to one GP for a same condition 14 times in a year. Why? Because there are a lot of other people who need that part. So that means we are not picking it up. We're not identifying a real root cause problem. And it becomes a cascade. Somebody had a back pain, and we're not saying because of osteoporosis is back pain. We're just saying, oh, back pain, let's treat you. It's not going to go away. And depression is not going to go away if you don't tell them what the problem is. So, and that's the confidence part, and the fear of falling or having a new fracture, depression, loneliness. That's where the community is suffering, and we need to do things very differently, whatever we have to do. Now that's Europe, the whole Europe, and UK is red, and I think it's more red than this, than what we see here, because we only included people up to the age of 89. So, which simply mean that prevalence of osteoporosis is further higher in the UK as compared to this, and in comparison to the other European countries. But we are living here, so that's something we have to face. But that's what the part of age when you mention menopause, and that when we start growing up to the age of 20, your bones are growing. And that's where I think we need to do the maximum attention. But that attention should not go away because we have to sustain that attention there. We mustn't forget that bones, although reach the maximum mass, but now we need to sustain it. So when you achieve something in your life, you need to sustain that good health, the good bones after that. But when we reach the perimenopausal age, they start coming down. And this is what happens, which we need to know, that somebody going to early menopause. But yes, we need to pick up those patients. And now, again, in Wales, we have my colleagues like Helen Munro, who is our clinical lead for women's health for Wales. And we're working jointly on these, that how we pick up those people who are going through the early menopause. Can we do something different? But that's a long way to go on that work. But with menopause, we know it's going to come down. But can we do something different to delay this? And it continued to come down. So, but that's where the problem is. But in this group, any man in this group today, other than me, by the way?
Yes, I'm here. Yes.
Oh, well done.
My name is Talochan. I'm Narinder's husband, so I'm listening to you as well.
Okay. Very nice to hear that there is a man, because most men are not interested in this, and they hate me after this when I talk to them, and I show them that you're no different. You're exactly same as women, and you reach that peak pose, and then you start going down as well, though not as much as women, but you do go down. But definitely, when we look at the importance and about the bone health and osteoporosis attention or awareness, men take it far less. It's not for me, it's for women, and particularly older women. That's a myth. So that's not true. And the answer to that is here. And so 1 in 5 men after the age of 50, they will have a fracture. But in women, it's 1 in 2. So imagine how much you will hate me after seeing this, that I'm telling you this bad news today, that if I'm talking to 10 women, after the age of 50, half of them could have a type of rigidity fracture, which means you are at a risk of osteoporosis. But that's science. That's what the reality is. But we are not aware of this, and that awareness needs to be increased in the community. And for men, when I say 1 in 5, it's higher than a prostate cancer, and it's more debilitating, more painful. And you heard about other things, that how much it affects us. But we can do something. So we have nice guidance, which is the one of the things which guide any medical doctor or a healthcare professional, how we should treat people. But we have Royal Osteoporosis Society's guidance on the osteoporosis risk checker. Now, anybody can go to the site and do the risk checker for themselves, but you have to sign the waiver form that you're taking your own responsibility to do that. And when you do that, you need to follow some sort of rules, that you're not diagnosed with osteoporosis and you're not taking any medications for osteoporosis. But then you can only seek opinion from a healthcare professional once you've done that. But by all means, you can do that and then follow the next steps. But they have to be done in line with your risk factors, family history, and your personal habits. And it cannot be just done on its own. So again, once you do the risk calculator using this risk checker, you have to follow everything else what it says. And there is a self-care plan in this. But we do this type of things. We can actually calculate your risk of having a fracture in the next 10 years. And then we can do different type of guidance. And again, it takes only a couple of minutes to do this, asking you a couple of questions. Do you smoke? Do you take steroids? Or do you had any previous fracture, or family had a fracture? And we just click a few buttons and you get a graph like this. And very easy to treat. But it's the awareness, it's that intelligence to see, asking that question, that have you had a fracture? Or the picture with the pink cast you've seen, not to ignore it. When it comes to attention, identify and record it in some sort of notes, that yes, I had a fracture, and I had a fracture by falling from a standing height, or with no pressure or no allergy, hence it's osteoporotic fracture, and we can treat it. And this is what we do. And particular part is identifying that somebody had a fracture. And then we do the assessment for them. And out of this, the most important part is what we are doing today, is that raising the awareness, educating everyone that how to do the self-care plan, why it is important to look after the bones. And we can treat easily. Treatment is not a problem for us. We got plenty of medication. In fact, we got like this days, we get a buffet. What you want, we can give you that. But many people will stop taking this medication. You'll be surprised. Only 1 in 5 people in the UK take the medication as been explained, because after 52 weeks, there's no pain. People forgotten they had osteoporosis, and it becomes silent again. And if something doesn't bother us, we don't bother that, and we stop taking this medication, and they come with a repeat fracture. So that's why we are telling them again and again that you continue to take this medication, and they have to take this medication for lifelong. We need to work on that. But that's the answer to that question. So it's a little science behind it, but I'll take time to explain to you about this. It's the first graph which talks about the relative risk. And you can see how the graph is peaked in the first year. So if anybody had a wrist fracture, that pink color cast what you've seen, within a matter of 12 months, you can have a second fracture. And that's where we need to work really fast to de-risk the fracture risk. And the only way to do that is identify that individual ASAP. And once you identify, you educate them, you train them, you work with the community teams together and treat that individual and protect that individual from a second fracture, which we try as a refracture. Once you start treatment, you can actually reduce the risk by 40%. And that's a really good outcome of these medication. We cannot prevent every refracture, but up to 40% we can. And this is one of the really outcome, or a good outcome, I'll say, in medicine. I'll make a little simplify for this. If somebody had a stroke, we only give aspirin or a blood thinning medication. Now, these medications are not 100% protective of a second stroke. So they protect up to 60-70%, not more than that. So by giving these medication for longer term, you protect it more. So that's the joy of secondary prevention. And these are the medications which we take. And these graphs just show that when we start these drugs, we improve your strength in the bones. So that's the blue line which is going up. And for 3 years, if we don't do anything, it stays the same. But even when we start after 3 years, the bones start to recover. So that's the second dotted line is showing you in all these graphs. We can still pick up some of the strength in the bones and make it more stronger. So, but if we don't do anything, that will definitely drop down. That's what the gray line is showing us in all these 4 graphs. So, but a little complex to understand, and simplified is that if we know this problem, we can do something about it, and we can make the bone stronger.
Doctor,
So I think
sure. Question.
Please.
Would we be entitled to like a bone density test, or is that too expensive for?
I can answer all those questions after, for sure.
Thank
you. It all depends on that risk stratification.
Right.
Somebody had the risk checker then done themselves, and they go to GP and they can do that tool which I shown you, the FRAX score. So it's FRAX. So it's available freely on Google, but I won't recommend you guys to do it. I will only recommend you to follow the Royal Osteoporosis guidance for osteoporosis checker risk. So you can do that risk, and I think if a GP find it out that you have got other added risk, by all means, they will refer you for the DEXA scan. And there are challenges of that, which I am happily share, that in Wales, as we speak today, we only have 9 DEXA scanners.
Oh.
We are short of 22 DEXA scanners.
Right.
So that's the time frame or the resource problem. But it's not only the Wales, it's in the whole UK. So it's not only the UK, it's whole world. We are all same. We haven't got that much resources to manage the volume of or a prevalence of osteoporosis we have.
There is a long waiting for DEXA scan.
So you're talking of 6 months on average in Wales, just because we haven't got the resource. It's not that we don't want to do it.
No.
So that's why we are using the tools, and the tool which I shown you earlier. Without a DEXA scan, we can treat people when we know that the guidance is there and we know it's a very low energy fracture. Why do we need a DEXA scan? Yes, it's needed for the specialist treatment, but at least, that tool is there to guide us. So that's where I think the aim is, let first fracture be the last. So if you see the picture there, it's saying it's a warning sign. So that's why we have introduced the fracture liaison services. And they are very effective in picking up the fracture and in treating them very soon and avoid that subsequent fracture. So when I cannot prevent the first fracture, but at least I pick up the first fracture. And I can tell you my rationale for that. So I just want to thank all my patients who have made me more knowledgeable or an expert, and rest all the team members, including government, the CAPSACs, and everybody else. And my staff is amazing. But I'd like to thank them for this. And let me stop sharing first and stop share. Okay. And you can still see me, right? So I think the question what you asked me is about the DEXA scanner. Is better that we link with a healthcare professional and see whether we need that particular investigation or not. If we need it, we will offer you that. And but if you need a treatment, we should treat you first. So there are two areas in that. Are we doing for primary prevention, or are we doing as a secondary prevention? So if you're just doing for sake of I want to see where my bones are, we can't offer to the population approach because we will miss for those who actually need that investigation. Hence, we have to do that. So it won't be done on NHS. And I will not recommend anyone to go private because there is no such guidance. It's not a screening tool. You need to screen yourself for osteoporosis. It's that risk stratification is more important.
Right.
So, and if we do screen and you find a little bit of osteopenia, what you do then? Do you start treatment? So just follow the healthy lifestyle, and that's the right population health approach. The smoking, alcohol, the diet, and on going for a nice holiday to Spain. So that's what I would suggest.
Okay, thank you.
But anything which is not clear, any questions, please feel free to ask me. This is your time.
On the previous PowerPoint, you mentioned the implementation of FLS.
That's correct.
What does FLS stand for, please?
Okay, it's a fracture liaison services. So I'm glad you asked me that question. It's difficult to remember. It's a bit of a mouthful. So fracture liaison services doesn't matter, like in whole area of Gwent as we speak today, that who's ever had a fracture, we pick it up while sitting in one place. We identify them. Once we identify a problem, we treat it. And we can follow them up. We can educate them. That's what the fracture liaison services work.
Right, thank you.
There are a lot of clever ways to identify fractures these days. And on that note, the fracture liaison services are very effective. They're very efficient. And Welsh government has supported this. And if you haven't read anything in the news, it's been, I think the government issued a written statement in February 2023 that they want these services to be established everywhere in Wales. And it's the establishment of the services to cover every health board. And on 30th of September 24, there is a second written statement from the government that we have got these services covered in all the 6 health boards in Wales now. But we have put a lot of efforts for the money across Wales, and so that we can provide that services to the community. So people don't have to reach us, we reach them. That's the whole idea of fracture liaison services. The second part, if I could share today, is the implementation. The implementation is based on the risk stratification again. So we actually come across minimum 20,000 fracture patients every year in Wales. So our priority is based on that we treat these 20,000 first before going to the high risk group, then going to women's health, then going to the people like children and everybody else. So we are following an implementation strategic plan, and we started with those who had a fracture, who have already told us, I am the high risk group and I'm going to have a next fracture in 12 months, treat me first. So that's what we're doing now.
It's fair enough, really, isn't it?
There is a channel known as Bone Health in Wales. It's a YouTube channel. And if you would like to go or you'd like to share with the communities we do put a lot of videos on that, and to see and share what we do, but also what community can do with themselves. So, so what you normally say is they say, like and subscribe. Ah, that's the one. Got another question?
Charanjit, have you got any question? I can see your hands up. Yeah.
Yes, please. I'd like to ask whether osteoporosis is hereditary, because my mum had it, and she lost about 5, maybe 6 inches of height from the point that she was menopausal to when she passed away.
Yes. I usually rephrase it back. What do you think?
I think it's hereditary.
That's correct. So it's become nice when you know your answers, but we just need to say that to ourselves. Yes, there is a strong genetic history, there is a strong environmental history, and that's what we put in the questionnaire. So when we put the questionnaire for yourself or risk checker, they'll ask you this question: is somebody in the family had osteoporosis or have broken a bone? And the loss of height, what you mentioned, it is so real because your mom sadly had multiple vertebral fractures. So, but again, slight change what we've seen with the aging graphs, that we have a better healthy aging and successful aging everywhere in the world now. So, so you might at a risk, but at slightly later date. So you will add extra 10 years until you see the impact of osteoporosis, if you do see. You might not see because you might be in that another 50% of the women who may not have osteoporosis, but you are surely at a higher risk.
Okay.
So you can also wait more now.
I also had a premature menopause when I was 32.
Yeah.
So does that increase the risk?
What do you think? You've seen the graph.
Probably.
So both the answers are correct. So you actually had a early menopause, or what we called as POI, premature estrogen insufficiency. Could be from different reasons, but yes, estrogen is lacking.
So she should have DEXA scan soon. Is that right?
Not really, not really. I'm not suggesting that. I think I'm suggesting is that we do the risk assessments. So that's where the osteoporosis risk checker and FRAX is for. And so these talks, we do not treat individual patients anyway. For individual patients, I've already suggested you need to have your separate consultation. But I think as a rule of thumb, when we have 2, 3, 4, 5 risk factors added, so that's where you need to do your risk stratification. So let's say somebody on steroids, the risk goes further high up. Somebody have diabetes, risk go further high up. Somebody's smoking heavily, the risk is further high up, or rheumatoid arthritis. So I think those are the risk stratification we have to do. So we need to follow the population health approach rather than an individual approach in these type of sessions.
So did you say that we can do osteoporosis risk checker ourselves, and then FRAX you get it done through GP? Is that
That's
right?
correct. That is correct. But the osteoporosis risk checker, when you do it, it's you have to do it little carefully. It's to make sure that you're not diagnosed with osteoporosis and you're not taking any medications, else it will give you a wrong diagnosis or a wrong suggestion.
So if you can share that link, osteoporosis risk check.
If you go to Google and if you just put that the Royal Osteoporosis Society osteoporosis risk checker, it will come.
Right. Okay. So
Because I believe because we're in a video there, it's better that people have got more ownership of what they want to do. Because if I keep sharing the links, it doesn't help.
No, that's great. I think So take home is that we should do osteoporosis risk checker ourselves, and then if that's any concerns on that, then see GP for FRAX. Yeah.
Be a little cautious on that as well, because it will increase your workload a lot. So, but you have to follow your self-care plan prior to that, healthy lifestyle. And yes, by all means, you do it, but be patient as well, because your GP may not have the appointment line for this, because their workload is massive. So please don't get too upset or annoyed if you're not getting an appointment, because you can imagine after this talk, if there are 100 people done it today and there are 100 appointments being asked for the same GP surgery, it increased the workload. So I'm just giving some practical views as well.
Yeah.
And otherwise, one of or the other GPs will get very upset with me. What the hell I've said? So you need to be, these talks are nice. When they go to the social media or others, it can lead to more misconception or some sort of the problems.
Can you explain the effect of steroids on osteoporosis, please? I take steroid inhalers for my asthma.
Okay.
And,
the inhalers as such is a very weak evidence, if I'm honest, that they can cause anything to the bones. So very little. But if you take tablets and that again above 7.5 milligram every day, and you take it more than 3 months or beyond 3 months, then yes,
right,
that's
okay.
a higher risk, not inhalers.
All right, thank you. Okay.
I think that's a great talk, and it was quite useful. Thank you for your time. Yes, and do you want to ask me?
I thought it was absolutely brilliant. Absolutely brilliant. Seriously, really well put together, well presented. So interesting. Thank you.
No,
thank you.
Absolutely loved it.
Yeah, but if there's anybody else
I was
who
going to
is,
say, is there? Will you be doing any more sessions? Because I live in Cambridge, so obviously, all the ones that are held in person, I can't attend them. So if there are any more Zoom sessions like this that you will be doing, I'd really appreciate a link. I'm in the yoga and meet.
Yes. So we do this talk every other Monday at 1 o'clock on Zoom. So there are a few more talks lined up as well. Are you on that Yoga Smile group? Yes.
Yes, I am.
Yeah. So I have started sharing the link there, so you will see me more. Yeah.
Okay, that's absolutely fabulous. Thank you. Job well done.
Thanks a lot, and thank you, Dr. Singh, for your precious time.
Yeah, thank you.
Yeah, it was really useful. Thank you. Thanks a lot.
Thank you.
Thank you very
for
much.
joining.
Thank you very much.
Dr. Manmeet.
Thank you. Bye-bye.
Thank you. Bye-bye.
Bye.